I'm going to turn it over to the crew here that's setting things up, and appreciate you coming and spending an hour with us, and let's go.
All right, so thank you so much everyone for coming today. This is the first Dean's Chat that the class of 2021 CBSR is hosting, so we're very excited. And thank you to Dean Franco and Dean Young for allowing us to continue to do this. Today we are welcoming KRISTEN Morris here today. She is the Chief Government and Community Relations Officer of the Cleveland Clinic. She graduated from Purdue University with a double major in communications and a minor in math sciences. And while in college, she interned for the Ways and Means Community Committee in the U.S. House of Representatives, and then she returned to D.C. after graduation to serve as a health legislative assistant on Capitol Hill. So she's been at the Cleveland Clinic since 2013. So please help me in welcoming KRISTEN Morris.
Thank you. Thank you.
Okay, guys, so I think you know basically how this works. It's going to be like a Q&A session, and then at the end we're going to try to reserve about 15 minutes for questions from you. So throughout, just think about things that you're curious about. So KRISTEN, could you talk a little bit about your time on Capitol Hill and then working in the biotech industry and how you transitioned to coming to the Cleveland Clinic?
Sure. Actually, since this is not an interview, I'm going to tell you the truth. But you can't tell anybody else in case I actually get an opportunity to advance further, right? So I was an engineer at Purdue, and it was industrial engineering at the time, and my boyfriend wanted to go to Washington, and I thought, oh, I'll go and get a Washington internship. So it wasn't like I had this aspiration to get in politics. My mom is a nurse, so she got her nursing degree the same time I got my high school diploma. So we were both sort of getting our careers going at the same time, and I was always, I very much admired her. And then when I went back to Washington, again, because I wanted to follow that boyfriend after graduation, I really lucked into an opportunity to get into the political environment. I think I would have made the world's worst engineer. I did change my curriculum around my senior year because I went my junior year to Washington, and I still at that point intended to be an engineer. But it really enforced, and I don't know how many of you have had a similar experience where you had no intention of going into medicine at some point or something else inspired you. But it was the most amazing summer, and over beers I can tell you what went down that summer. It was crazy. And I walked away from it thinking, I can't believe people get paid to do this. This is awesome. So I really was motivated to get back and do it again. And honestly, I still feel the same way. I cannot believe I get to do something that I'd probably do whether I got paid to do it or not. Be an advocate and get engaged in public policy and democracy, and it's a wonderful career. So I did that. I was on the Hill after graduating for 4 years, and then was because I still had a lot of science background, I was recruited to run the Washington office for the American College of Nuclear Physicians and Society of Nuclear Medicine, and it was during a lot of the Clean Air Act and Clean Water Act work in the early 90s. So the low-level radioactive waste disposal and the medical use of radioactive isotopes, et cetera, was a very big issue. So we were the peacetime application, largely working very much hand in glove with the nuclear energy community. But I learned an enormous amount. Positron emission tomography was just coming out, and we were working with all the academic medical centers to figure out how we would license all the materials, whether as it goes through the FDA process, because you reconstitute it on site, and so it's not like you manufacture this stuff. So it was a really, really neat immersion into everything from FDA to medical regulation, et cetera. And then that led into a position that GE took notice of me, and they recruited me to be in their trade association, which was at that time it was called HEMA, but it's now it's called AdvaMed, so it's the Medical Device Association. And then I got recruited to go to the American Medical Association and then to American Hospital Association, where I ran their lobby shop for about 8 years. And I'm giving you the long version of this story, but it's kind of relevant to the way that I think about career development and how you sort of lead your life. You just take advantage of what is the best in front of you. And by virtue of all of you being here, you totally get that. If you're going to do something, totally go for the best. And at the time, the American Hospital Association was the best, and I still believe it is, trade association in DC. And I really angled my way to get there and get their attention. After being there for 8 years and they were forcing me into management, the thing that's wonderful about DC is that they really value strategic thinking and relationships and networking, et cetera, and that kind of value, but they do not measure management skills. So here I'm getting all these management responsibilities and had absolutely no clue what I was doing. So I didn't really have the funds to go to graduate school and get that education, so I decided to go corporate. And that led into the following about 10 years of going into basically pharmaceutical and device companies. Great experience from a management perspective, really, really effective in understanding how to do corporate social responsibility, which we can talk about if you care, like what we do here in a community level. And I think all of that built up for this job. I mean, there's no way that I could have done what I'm dreaming of doing here and what I'm having to do for the Cleveland Clinic had I not have all those serendipitous experiences that built this resume. That wasn't really, it wasn't the resume that counted that got me this job. It's truly getting the knowledge to unwind, what the superpower is of the Cleveland Clinic and really do what it needs to do to both be a thought leader and an anchor institution. So there we go.
Great. So in concern with your letter with Chairman Fred Upton, I know you spoke a lot about graduate medical education and where it's moving in terms of federal funding and spots for residencies. So how do you think that's progressed since your letter in 2015, and where do you think it's going?
So that's a good question. In 2015, we were extremely worried about a movement to reform the way GME and specifically indirect medical education, IME, is funded. And Medicare is essentially it's a multiplier on Medicare payments. So by virtue of a resident following a physician around, there's an assumption that it takes extra work to tutor that student as they're going through and taking care of Medicare patients. When it was initially enacted, the concept was really, really supposed to be sort of a pass-through, like just a grant to those who are training the future of medical professionals. So there was never an expectation when it was first passed in like probably the 70s that this was intended to be accounted for and that there was a 1-for-1 ratio on every hour and every dime that was spent to teach a medical resident. It was really just a subsidy. So fast forward to about 10 years ago, people started going, hey, well, what indirect? That sounds really squishy, and what are we really spending that money on, and are we getting the return on investment? And they started really exercising that formula and questioning how all academic medical centers were spending this cash. Since it's a multiplier on Medicare reimbursement, and since we have the highest acuity in the nation, we are the single largest recipient of medical IME. So when that was the one that was in the crosshairs, we were like, oh my God, we got to come up with a plan to either prepare for that shoe to drop, because my job is to do two things. One, never let my organization be surprised. Now, sometimes it happens, admittedly, but my objective is to never let the Cleveland Clinic be surprised about what's coming at it, both good and bad. And then the second thing, let's mitigate it and drive it and make sure it's going in a direction that we feel is appropriate for the future of medicine. So we started writing to the chairman of the committees to let them know, along with coalitions and others, what we feel the future of IME and GME should be. And because the thing that was so frustrating is that here you've got Congress saying, we're just throwing funny money at you and we should remove that, and that's a big cost savings, that's just a windfall for you guys. And then our trade association and ourselves, we're all saying, no. In fact, we've got to double it. We are completely underfunded. I mean, you couldn't have a bigger chasm. And for somebody in the policy world, that's like malpractice. You do not let that sort of thing lay out there, knowing that you're not advocating or educating your policymakers on where you really believe you should be. So we started this process. And then Dr. Stoller, we went and actually, he briefed Congress about 3 or 4 times, maybe 2 times. Seems like it was maybe 3 or 4 times. So, we would have staffers that would come and he would, kind of go through the facts of GME, and then they'd ask him questions, and we'd bring him around to the Hill offices just to get people educated on why we have this chasm. And then we started thinking about different ways we might be able to resolve it. Transparency is always a good way to start. So don't cut us. Let's figure out what really is going out there. Maybe we could, come up with that. actually the education started to work, and the politics have changed. So right now it's not on the front burner. That's not to say that it couldn't change in the middle of the night. I think we have an environment where there's a lot of unpredictability, so it could always come back again. But there's on the Ways and Means Committee that has primary jurisdiction over this. Right now, we have a fellow that is a Cleveland Clinic physician that is on the committee advising the chairman on this very issue. So it really kind of helps. His name is Dr. Hans Aurora. He's a urologist that worked with Dr. Jones, who's our president of our regional hospital. So this is, so we kind of got an in with somebody who knows what the real facts are. So it's not as much of a scary issue as what it was back then.
Although, Kathy, do you remember what the numbers were on the number of ERAS applicants? I think it was around 60,000 this year, and the number of GME slots that was available, it was just a little over 50,000. So probably a 10,000 mismatch. They had more, but they had more applications this year through ERAS than any of the other years. So anyway, it's a lot and raises a lot of concern.
U.S. grad, so they don't get scared. U.S. grad is about 1,000.
Yeah. Yeah. So I was just going to say now, CCLCM students don't have anything to worry about.
Yeah. Well, and just, because, the GME is, again, the residents, payment. And the data back then, I haven't gotten the latest data, but it costs the Cleveland Clinic about $130,000 a year to train an individual fellow or resident per year, and about $82,000 of that is actually reimbursed by the government. So the clinic is already, that's part of a large part of our community benefit that we report every year, is taking care of the future of medical professionals.
Okay. So moving on, in terms of the ACA and the changes that have been happening recently with insurance policies federally, what do you see changing in the coming future, and what is your role in dealing with these adjustments?
All right, so that's a really big question. I feel like if you want to step back and think about if what our obligation is to be a thought leader, we have a really big role in helping design and form the future of medicine. I've been talking a lot about and doing a lot of reading around non-market forces. And so, because I'm trying to think of what's the language that's going to be the common language when I talk to my colleagues at the Cleveland Clinic about why do, big industries and anchor institutions invest in doing this kind of work. And it's because if you define the environment in which you're going to operate in, you're going to obviously be more effective and successful, and all the way around everybody wins when you engage along that line. And that's just one of the major pillars of that whole non-market forces concept. So as number 2, arguably in the world, I think we have a pretty big obligation to influence and design the healthcare and delivery system that we operate in. So Dr. Cosgrove also is willing to do that. It's kind of hard to say this because you see him on television, and he'll be willing to do speeches, fairly frequently, and he networks very well. But he loathes politics. Like, seriously cannot stand everything that I do, which I kind of take personally. But he does it because he really knows that we've got to, start having that conversation. We can't just sit here and go, oh, they're so ridiculous, and expect things to get any better. So right now, his basic talking points are around the original Affordable Care Act's mission was to make care more affordable and higher quality and improve coverage and access. It really was those 3 things that they were intending to do. One could argue it expanded coverage, and arguably access. The quality metrics that were part of the Affordable Care Act did improve quality and got some more clarity around that. It's the affordability that we really haven't succeeded in doing. And in fact, the insurance market is cratering, the private market is cratering as a result of a bunch of dynamics that I probably don't need to iterate for you. You've probably seen how you can't regulate and expect the actuarial analysis to come out in a way that's sustainable long-term around the way that it was designed. So that's the part that's the most broken. I would argue the Medicaid component of it was the most important social policy I've seen in my career. And that's, I've been doing this for about 30 years now, and I just think the idea of providing coverage to the low-income worker, a population that doesn't usually get coverage from their employer, and then keeps that population in the workforce and hopefully maintaining their chronic disease or their mental health. 80% of the individuals that did take advantage of the Medicaid expansion population, or benefit rather, 80% were in it for some mental health need. So whether it be, classic mental health or addiction services or whatever. So this is more or less a chronic disease environment that we're talking about. And if not managed well or medicated well, you can see how they would easily not be able to stay in the workforce, and they're easily derailed and taken out of the workforce, which should be the goal. You want people to be taxpayers. I mean, I'm going to take another step back and say the number one core job description of a legislator or any policymaker is that they are stewards of your tax dollar. Give me an issue and I can pour it down to money. It's money that they deal with. And so that should be their mission, is to keep that taxpayer going. So, all right, so back to the affordability. So the private market is cratering, and then there is an ideological rift among Medicaid, and whether that's increasing entitlements, because there's generally a Republican feeling that you want to minimize government, that should not be the role of the government. So those are the two major components that are in question. And I can go through my presentation and hit the highlights on what's really happening if that would be of use. But I think and actually I should ask you, do you want me to run through that, or do you feel, you've seen it? Did you see it?
Oh, it's a wonderful, brief, 5-8 minute survey of things, but it's up to them.
Yeah, that's fine. You want to do that?
All right. Here's this dynamic is what drove the election. If you look at the top line, that's the negative perspective of the Affordable Care Act. And the only time it was actually more positive was almost when it first started rolling out. And then ironically, now at this point in time when we're about ready to repeal it, it's getting more positive again. So it's really messing with the legislator's head. Let me show you another slide. So if you do the basic right track, wrong track, most people right now feel that the legislature is on the wrong track with regard to healthcare policy. Now, politicians do like to represent the public. And here all along, they've been told they needed to take action. And now that they're ready to take action, they're being told, no, don't take action. So you've got a whole bunch of confusion going on in terms of how they best serve the people. So let's go through what the Affordable Care Act, really the problem with it is. First of all, this is not a policy discussion. It's a political discussion. It was more about the way in which the act was passed. And if you may remember, back in 2010, in the dark of night, they pushed through just on a random, using the same budget rules that are being used now. They pushed and forced this legislation through. Even the Democrats were angry about it. We had many, many Democrats who were just outspokenly against President Obama at the time. But at the end of the day, it was the only way to get it through. And the Republicans swore that we would never, ever let this survive. They're going to repeal the doggone thing, and that this is not the way to legislate. So what their answer is that they're going to do exactly the same thing back to the Democrats. So this is a total train wreck from a legislative perspective. What everybody will agree with is that, like every piece of legislation, it is, again, an imperfect bill. And ever since the Social Security Act has been passed in 1965, when Medicare was first established, it has been amended. This is the first time in my career where you've had 7 years where you haven't been able to amend the act because of the politics being so horrible. So it's been festering for all this time. So let's go through what the American Health Care Act is intended to do. 1, repeal the ACA. 2, stabilize the private market. 3, equalize and control Medicaid spending. This is the Medicaid expansion question. And 4, do it within this Byzantine structure called budget reconciliation. So they can't do all those things. They can only do a small part of it. Let's go to the next slide. So we have 20 million. Let's talk about who is really affected by this. As I was saying earlier, let's kind of look at the population that was covered under this new ACA stuff. The vast majority of people are under 250% of poverty. That's under $16,000 a year. So this is low-income working poor. Click again. And if you look at by age, it reinforces that the vast majority are under the age of 55. So this is a workfare bill. This is not, your classic sort of entitlement program. The coverage today, if you look at that green and yellow wedge, that is what that whole population that we're talking about is about. That little teeny wedge. We spent $1 trillion just helping that little teeny wedge of people. But by virtue of those people being helped, it's affected the entire Medicaid population because they're trying to reform now the whole basket of the way Medicaid is managed to come to some sort of compromise. And we still have all these uninsured people out there that could get, theoretically larger or smaller depending on it. The vast majority of people like us in this room, we're not really affected by this. So it's an interesting dynamic when you think about where the voices are coming from. The reason it makes such a difference in the state of Ohio and why the Cleveland Clinic is so involved in this is that the Medicaid funding at the state, which is half the state budget, by the way, is Medicaid funding. 65% of it comes from the federal government. So they really hold all the cards on how we run our Medicaid program. Let's go again. So the budget rules allow, remember I said the fourth thing is that they have to do it in the way budget rules are designed. You can only affect monetary elements of it. So a lot of the insurance reforms, like pre-existing conditions and the way you can multiply the different actuarial analyses that are in this bill that would really stabilize the insurance market, when it gets to the Senate next week, they actually won't even be germane and they're going to be stripped out. So this is where you're getting them to say like, well, phase one, we're just going to repeal and then we're going to come back and we're going to do the rest of it. I mean, this is so ridiculous. They're going to try to jam it through the repeal part. That's the only thing they care about, is so that they can tell all the voters, yes, we repealed this puppy. And then basically, they're not repealing at all. They're just destabilizing it even more because they're going to take away all the taxes that funded it. So you're going to have no way to fund it. And there's no way to make sure that people actually buy the coverage because the mandates require that and the penalties against the employers. So they're completely just annihilating it. They're not repealing it. They're just destabilizing it even more. They are going to do, we're going to talk about this in a second, market fixes, and then we're going to talk about Medicaid reforms. So the market stabilization, one, they're going to widen the spread of premiums from 3 to 1, which it currently is now, to 5 to 1, which means that they can charge the older, and it's by age, older individuals 5 times as much as they would charge you, for example. By 2019, there's going to be a 30% penalty if you either don't sign up for coverage right away or you have a break in coverage longer than 63 days. And then by 2020, they're going to replace the current subsidies with refundable tax credits. So right now, the government actually gives people additional funds to buy the insurance if they want it. But now instead, you're going to have to report on your taxes and you can get a tax credit if you want to toward your coverage. And then there's capped at this level, no more than $40,000. It goes up to $4,000 rather, up to 60 years of age. On the Medicaid objective, one, they want to repeal the expansion. 2, they want to cap the way in which they fund Medicaid on a per capita level. And 3, they want to go and just give the states a ton of flexibility. So they just want to give the states all this money and then say, you guys be creative, you figure out how to do it. We're not going to put guardrails around it. If you want to, fund everybody at very limited levels, but you want to fund up to 500% of poverty, you have at it. If you want to fund, up to 50% of poverty, but fund everything under the sun, you have at that too. So they really want to give all this. So we have the ability to experiment at the state of Ohio level if they go this way. Downside is we have a very, very conservative legislature, and so we might be in a very unfriendly environment for how this money is used. A recent study that came out 2 weeks ago said that the red line is how much we would actually lose in terms of Medicaid support at the state level if indeed that per capita cap was put into play. So we have stand to lose a lot of funds, except for the fact, remember, affordability was one of the ways that we wanted to try to achieve in this bill. And this looks very much like a bend the cost curve. And Dr. Cosgrove talks about that all the time. We really do have to figure out a way to make care more affordable in the United States. So theoretically, if we were more efficient and kept people well, and if that's what our system was intended, was incentivizing us to do, we could achieve this. But there still is a lot of money at play. And then the Congressional Budget Office came out last week saying that tons of people were going to be dropped from the rolls. Again, one could argue both sides. This is just the monetary provisions that they're able to amend. It's not all the amendments that they really need to do to truly stabilize this plan. So they're right when they say, well, the CBO didn't really analyze everything we want to do. Well, because you didn't put everything you want to do in the bill. So the CBO can't kind of anticipate and pretend they think they know where you want you to go. So if they do what they're doing right now, yeah, it's going to totally destabilize the market because that's what they're planning on doing. So a lot of people could lose their coverage. So it's a really, really, it's not a simple discussion. So this is where we had Steve Glasses, our CFO's staff, stand up and say how much this would affect the Cleveland Clinic. We tried to model this out, and at the end of the day, the Cleveland Clinic, and if you go to the next click, the cost and incremental volume of how this would affect the Cleveland Clinic, we think we would lose about $100 million a year. So it could be a pretty significant cut to us. There we go. So what's next? We have a vote this Thursday, and if it doesn't make it through the House, this puppy is dead. I know what everybody reads in the paper makes you kind of think, there's no way this thing is going to pass. This is so controversial. This is a manhood test. These guys are going to pass this baby if they can, believe me. Then it goes to the Senate next week, and it's the same thing applies there. They are really, really going to pass this, but they're going to have to strip out parts of this bill that are not all about the finances, so you're going to even have a more pared down, more destructive bill coming out of the Senate, arguably. And then both bodies will have to pass it again before it goes back to the president. If they get something to Trump's desk, it's going to be signed. And then we're going to spend the next so many months or the rest of the year trying to fix this, if that's what they end up doing. I really don't, I'm not betting money right now. I think this thing could actually be repealed, and it could just leave a very destabilized marketplace out there. And then we'll be very busy for the rest of the year. So that's it.
All right. Thank you for going over that. That was really helpful.
Answers that question.
It does. It definitely does. So kind of going off, you talked about making care more affordable and kind of spreading out care to make sure that everybody is covered. More on making sure everyone is covered in terms of medical care. I know that you've spoken about expanding primary physicians and kind of trying to create subsidies to allow more spaces for primary care physicians and to force more just kind of students to go into that direction. So where do you think that's progressed, and how do you think that's moving?
The interesting part, and I think I even have data that I might be able to quote in here, for as many physicians, primary care physicians, we need the equal amount of specialists. When you look at the aging of the population, it's not like it's one or the other. We really do need more caregivers all the way around. So, back to the point about needing more GME slots to make sure that we're training the future, clinicians of tomorrow. And then also working at the same time at the state level to make sure that we can have people operate at the top of their license. So a lot more advanced practice individuals across the board, and taking advantage of technology at home so that we can reduce the amount of time that people that are truly the specialists have to spend seeing the individual patient is where we're trying to push. And I think that individually our challenge is going to be if we the pendulum is always a swinging dynamic. So if we come all the way to the point where we really are depending on advanced practice and devices to, assess the patient and keep them as well as possible, how do we make sure that we have that patient experience at the same time and have that relationship that you need to truly understand what's best for that individual? And so I think that we're going to consistently be stretched to understand where that is. I think that I have a totally other presentation. Cleveland, Ohio is the second largest fastest growing city in the entire United States around eds and meds, people who are entering into and being trained in the field of medicine. I feel like that's probably one of the fastest growing sectors in the entire economy right now, because there's such a need for having people who need care. And it's not like you can have somebody you can't export that commodity. We can't, really have people in another country caring for people on the ground. It's really a very local, very hands-on experience for the most part, at least in this day and age. So, bottom line is, primary care is necessary, but we're trying to figure out multiple ways to solve for that wellness and that primary care experience at an affordable way and a reasonable way. But specialists are equally as important, and I'm going to stop there because I could keep talking about that forever. But
So I know you mentioned in the beginning of this talk how you really liked your profession because you get to advocate for patients. So what do you think our role is as medical students and the role of individual providers in the place of patient advocacy?
So a couple of things. There's nobody that tells the story better than you. And the experiences that you have and the fact that you can tell the story of what happened to somebody that you were working with or cared for, et cetera, that'll open the door. And then what ultimately is also needed is the data. So by virtue of all of you being trained more intensely in the research side of your field, I think the thing that we often lack is that we don't have the data and the real emphasis that can help somebody make an appropriate policy decision. So you have, in the absence of that, a lot of legislating by anecdote. Oh, I know my best friend's brother's sister had this particular situation, so we need to do X as a result of that. And, I don't think legislators do things, stupid things on purpose. I think they do things out of ignorance. I really do. And, they represent us. And if that ignorance is there, I think we only have, ourselves to blame. So, so to be precise, absolutely, having those relationships and those trusted relationships with a policymaker at all levels, even down to your council person, mayor, you name it, whatever, really makes a big difference. But the thing that we really lack is the data. And Dr. Young and I have been working on how we deal with chronic disease, specifically diabetes. We have great data on diabetes, but we also have great data that says no matter how much you do on education and diabetes, that things don't necessarily change. I mean, you can test forever, and it's still testing, and they're not changing their behavior patterns. So what are the things that we can do to change behavior patterns? And I think you started to come to the table with some really good experience that the Cleveland Clinic has had that is getting people's attention. But we still, you've been in the meetings, they still want the hardcore dollars, and they want it, nationally and down to a level that they can replicate. So I don't know if that helped, but I really feel strongly about, I think you guys have a really unique skill set of being able to do both.
So more on that front, I know you do a lot of things between the Cleveland Clinic and community outreach. Mm-hmm. So could you talk about a little bit more of those programs and what we can do in terms of getting involved?
So the anchor institution concept is not a new concept. I know since like the 90s, people have been really studying about how an enterprise can affect and define the community in which it lives or exists. And for whatever reason, hospitals kind of have been doing it all along, but more by accident. And I can give you some examples. But in the recent years, or a couple of years, there's been a really great series of models and toolkits being put out there about hospitals as anchor institutions, and can we turn our communities around? Because a lot of us started building and growing in depressed neighborhoods. So you see some of the world's best academic medical centers surrounded by really at-risk communities. Look at Baltimore. Johns Hopkins is a good example. And in those environments, you've seen Pittsburgh is another one. I mean, I could go on and on. In those environments, hospitals as anchors have started to do things that they are now taking credit for. Like Johns Hopkins, across from their main entrance, there is this huge piece of land that they were able to obtain and redevelop and then create affordable mixed-use housing that now is being credited for beginning to turn around the neighborhoods around the enterprise. Now, if you know why they really did it, was because people were not willing to come into their brand new shiny institution because there was all these drug deals and people were getting accosted, and there was a lot of violence in the area. So people were refusing to come into their facility, and they're like, we got to do something about this. Why don't we buy it? No, what do we do with it now that we own it? Well, maybe we'll put up some housing because then maybe we can have something for our employees. I mean, literally it was motivated by something that had nothing to do with economic development. But now when you ask them, they're like, we're so smart, we're so wonderful, and we did this, and you should follow our lead. But this is the way it happened. So we know that this works, and that there is this economic, we have the data. That it's a really great way to return an investment back to the enterprise, to give back intentionally to the community. Some institutions feel like their role is to be philanthropic. And that frankly is not what I think is the best thing to do. There are a lot of us still do this, and a lot of companies still do it. And then the minute that person leaves, that philanthropy stops because it was all about what was in the heart of that person. I'm not saying it's bad, but it's not sustainable. But really is sustainable is if you do something that really is a return on that enterprise, and then it is also amplified because it becomes like a goal of the enterprise. And in my opinion, that kind of economic development is spot on. Because it, not only does it create a safe environment, and not only does it, create jobs and, an environment where your employees and a loyal workforce and et cetera and so forth, and mixed use, and then the property values increase and taxpayers, become more prevalent, which we are very dependent on tax income. It kind of, comes back. So I feel like doing what we can to create a better educational environment, because that's what you need to have a healthy, neighborhood. You need to have healthy schools, and in order to have healthy schools, you have to have obviously good teachers, and if you have good teachers, you've got to have a good infrastructure. I mean, so it kind of becomes all together. And as an academic medical center, these elements are really aligned with what our mission is. So there's that component, which you would normally not think of as a community effort, but there's that. Then there's those parts that we do as part of building the infrastructure for population health. And that's where we would get involved in helping our community network be as effective as possible. So whether it be working with United Way and the 211, which is the wraparound services that we don't want to replicate, but we want to help 211 be really effective so that as we build our population health models in the community, that we can have those navigators that can say, all right, you came here because you're, having these horrible migraines and you're having your asthma, needs to be contained and treated. But, how's your living condition? We don't want to manage that, but we want to have 211 and the people who are there that can help somebody find safe housing, or, I can tell, you seem like you're really stressed out. Are you in a safe home? We don't want to go in and become the social workers for domestic violence, but 211 can. So we really are obligated to be connected with our community services as an enterprise to do that well, not duplicate it, but help it be effective. So that's the kind of stuff that I think is important. I mean, I could go on and on about that too if you want me to. But
So last question, I think, before we open it up to the audience for some questions of their own. But could you talk a little bit about what went into getting the Cancer Center off the ground? And I know that there was a lot of different funding things that happened with that, and just recently opened. So what's been the legislative process behind that and the community process?
And that's an interesting thing, because very little came from, to nothing actually, came from the legislative process. This was 100% done out of the Cleveland Clinic and philanthropic support. I think that what we were involved in is the modeling for what's going to be the ongoing operational future of cancer care. I don't know how much you know about reimbursement. I remember, give me an issue and I can boil it down to dollars and cents. But cancer is infusion, inpatient or outpatient infusion therapy in centers that have been proliferating around the cancer treatment. Largely the margin is around the pharmaceuticals and the cocktails that are provided to the patient. And that spread, because Medicare pays a lot for that, but actually the provider can get the product at a fairly reasonable rate, and then the providers keep that spread. And there is an absolute incentive to have these outpatient infusion centers rather than have it be done at home, which it can also be done at. So payment policy drives behavior. So as the insurance industry as well as Medicare started looking at, that doesn't really make a lot of sense. Perhaps we should incentivize people to get their care at home and kind of start dialing down that outpatient facility or even inpatient care dynamic. We had to run over to Steve Glass and oh my God, your modeling might be wrong, and we might have to think about this a little bit differently about what the future of this facility is going to look like. So I would love to say I helped. Actually, I hurt. So in this case, it was more that we don't want anybody here to be surprised by what's coming at them. So my role was usually to provide bad news, that this is going to be not as profitable as what you might have originally modeled it out to be. It's very hard to get funding from the government for facilities and capital like this. We did get $1 million which was not a lot, but we're not giving up. We did get $1 million for the health education campus. That funding is going to go toward developing it's for the technological infrastructure. So it's all the wiring in the walls that's going to be there to support the HoloLens and some of the virtual reality and some of the other technology that's going to be used in the building. So we did get $1 million for that. We did not get any capital funding for the Cancer Institute, but we helped promote it by getting Vice President Biden involved, and we made sure that Dr. Bulwell and Dr. Cosgrove were front and center in the Cancer Moonshot, and we took advantage of that messaging to really talk about how we're redesigning the delivery of cancer care around the patient as opposed to around the doctor. No offense, but that's the way we always do build buildings, is around the doctor historically, and this time we really said, wait a minute, it should be about the patient and their family when their world is turned upside down. How do we really think that they should be cared for in this horrible time? And that's a great story. So we used politics to echo what the purpose of that facility is, not necessarily fund it, though.
So we can turn it over to the audience at this point. And if anybody has questions, we can bring around the mic to you. Chemi. It's not amplified. It's for him.
We're going to use that. Yeah, that one right there.
So I know that Cleveland Clinic is involved in other countries as well, like London and Abu Dhabi. And I know that in Abu Dhabi they have a different kind of healthcare system. But you've also spoken about how you have worked towards changing how we approach healthcare here. So could you talk about how Cleveland Clinic is kind of influencing these younger healthcare systems?
Oh, God, to me it would be like Candyland if we could go into another environment and start from scratch. I mean, just imagine if you were to say, here's a blank slate, how would you actually like to deliver healthcare? And I kind of thought of as the UAE as being one of those potential opportunities. I haven't been involved in it as much as I would like. I mean, I'm really dedicated to the domestic side. What I can tell you, and some of you may be more familiar with this than I am even, it's just an amazing experience because, first of all, it's not like the Cleveland Clinic culture can just be plopped into any environment. I mean, it's kind of like what I was saying before. We have a tendency to build things around us. I mean, that's where it's just human nature. And I think the way that the Cleveland Clinic went in and worked with the public hospital there, Sheikh Khalifa Medical Center, was just brilliant. And had an opportunity to immerse our caregivers and our management team in the culture and just listen and see and observe the way it was currently operating and what was expected. At the same time as building this amazing world-class facility with the eye toward how are we going to do research and medicine and technology in a way that can be a magnet for the rest of the world. Because research is hard to do, as you know, and again, could you create a regulatory environment that could make it friendly to doing research and cutting-edge medicine, and have the facility and infrastructure to support that? So it was just this really great vision. All right, so started there, understanding the culture and kind of feeling like how those things are. It's a relatively young country. It's like 42 years old, 44 years old. Is that about right? Are you from the Emiratis? Okay. Is anybody here from the Emirates? Because I don't want to, if somebody's more informed on this than I am, I just think it's fascinating. So you have, a relatively new regulatory system on top of this. And so you have this very young yet increasingly wildly wealthy country saying, okay, let's do this right. Yet they're running really fast to do everything right. So they started off with an economic development corporation that was the one that reached out to us, and the story is that the mother of the crown prince said, I don't want anybody to have to deal with what I've had to deal with, where I'm getting my care in my last days, tens of thousands of miles away from my family and loved ones. Please bring it back to my country. And so it was emotionally driven. It was the right thing to do, but it was managed through a development corporation, Mubadala. And then handed over to the health, public health agency. Another regulatory structure. So we build under one structure, then we hand it off to another structure. It sounds very familiar, like, very regulatory. Da, da, da. Well, now it's been passed back over to the other regulatory structure. So they're building an insurance environment that can support it, an entitlement environment that can support it. But one of the regulations, I'll just give you an example of that they had to deal with right away, was malpractice. So malpractice in the Emirates, before we came, that it's not like you just get slapped with a lawsuit and have really expensive insurance around it. You actually get imprisoned. So it was really hard to recruit people. That was like, well, you don't really get that insurance thing. Good news, don't have to pay that premium, but bad news. So that we had to really work with them carefully to redesign, something as basic that we take for granted here. That you don't get imprisoned, by the way, in case you didn't know that. But anyway, so we don't get imprisoned anymore. But it's like, it's that level of detail that we really had to work, with the environment to go through. And then recruiting the caregivers from all over the world and licensing everybody from all over the world. We wanted a third from the region, a third from the U.S., and a third from everywhere else. And so we wanted to have a truly diverse culture, and it's just been really fascinating. So we're now in an environment, and this is a longer answer than I probably should be giving you, where now the financial element is hitting, because at the same time that this really started hitting, its glide path was about the same time that the oil prices tanked. So now they're having to figure out a way to be more austere and financially sensitive about the way this facility is being run. So now we're it's getting the pattern of how do we create an affordable, like we are here, but an affordable environment to really care for the population. And then it's just, again, in this culture that's a little bit different. For example, we have a 30% no-show rate because it's just like, yeah, I'll show up if I really feel like it, but that's not the way we do it here in the United States. We still have a high no-show rate, but it's not 30%. So how do we make sure that we're taking the best use of our caregivers? Just lots of details, but it's not as pristine as what you might think. It's not quite Candyland. It sounded like it, that we were going to be able to design the perfect system, but I think it's going to be it's a great model, and the world has been looking at us. It's truly, I think, it's going to be one of the best case studies ever.
Other questions?
Sort of shifting gears back to the domestic, one of the questions I've always had is, so GME funding, which I know you touched on a little earlier, to my knowledge, the funding was frozen in Congress since like the 1990s, 1996, I think. And so my question is why, considering the need for more funding for GME is so obvious, and one would assume that it would be a bipartisan thing, baby boomers growing older and all of that. So I was wondering if you could touch a little bit on that.
So the story that they hear is, first of all, it's an environment where people don't really want to use entitlements. There's a big anti-entitlement sort of feeling in general. And it gets back down to that, what are we really paying for in this GME area? When, most medical students pay for this, experience of being in this, this educational environment. So they feel like, that these academic medical centers are getting this massive windfall from the government. We have these beautiful buildings, and we have this great infrastructure, and it's perceived that, what are you doing that deserves this kind of, again, windfall versus your community hospital that doesn't have the benefit of getting that kind of income. So it's looked upon as being, just unfair and unbalanced, especially since there is a way that you can charge for that as an educational benefit. And especially since there's another perception that you're getting cheap labor, that there's these students who are, not getting highly paid, and yet they're doing all these services to the Medicare beneficiary that's being billed. I mean, it's again the data in the story. I mean, I could make the argument. To be an advocate, you have to really understand that it wouldn't be an issue unless there were two valid sides of that argument. So there's a really valid point here that people don't understand where this money is going and why we can't figure out a way to support, just like every other academic center. It's not like there's a GME multiplier for physicists. It's just, that's just not the way the rest of academics works, except in healthcare. So it's really, it's just gotten complicated. from that perspective. Yet the system has developed around this. So if they want to make a change, let's talk about why they want to make a change, and let's create a soft landing to what is a better place and a more common sense approach, which is what we were trying to engage in that discussion. And the first step is transparency. Let's really talk about where this money is going and how it's being used. In my career, we used to be able to expense on Medicare the cost of Christmas decorations. Okay, they can't do that anymore, but that at one point that was there. And then when they started saying, let's get transparency in your cost reports, then they started peeling away all these perceived frivolities, and now we have more accuracy around that. And if they feel that the same thing is happening in GME, well, let's talk about that. Let's look at where the money is going, and let's have a data-based discussion around it.
Any other questions? Mikey first, and then Adam.
Thanks again for speaking to us, and I especially like your professional background because I was an engineer before. So
Oh,
it's
good.
interesting. Ties together.
From Purdue?
No, but yeah, grew up in the Midwest here, so kind of. So trying to think of kind of linking maybe some of these like past professional experiences, maybe think about more of the devices and developing innovations. I think one question mark uncertainty is always reimbursement. If we come up with a new medical device or a new medical procedure, how is it going to be reimbursed? And even for things that are existing, you're talking about when we have new capital investments, what's the payback? And if the reimbursement is changing, either existing ones or how do we put in, if there's a new one that's established, how do you gain confidence in what that reimbursement will be for your modeling, and in what ways can you actually like kind of nudge it to be in the favor of innovation?
Right. So my biggest aha moment was about 1992 or so, when cardiac atherectomy was just getting approved, and we were trying to get then called HCFA, the Healthcare Financing Administration, now it's called CMS, to approve this. And I'm like, this is so much less invasive than open heart surgery, and it's all these people who have hypertension, and we can clear out this plaque, and this is awesome, and it makes the longevity is da-da-da. And I literally had, and here I'm just like this Pollyannish girl, I literally had this regulator at HCFA say to me, you have to understand that my model is based on a dead patient is less expensive than you keeping that patient alive longer under Medicare, because they're not paying taxes and they're just costing me money in perpetuity. So I'm like, oh my God. So this whole argument around live longer is not working for you. And it was like this huge, so I had to prove that this person, to make a difference for technology, the real argument should be based on the productivity of that person after having that procedure. So if you're keeping an 89-year-old, infirmed, bedridden, lovely woman alive longer, that's not a good argument for Medicare, not working for them, or Medicaid, or anybody. But if you're keeping, a 52-year-old, back to workforce, physically active, not going to go on disability, now we're talking. So that's the kind of data, outcomes data, that ultimately, it's that economic outcomes data that's really hard to sort of do when you're going through a clinical trial. Because you're usually dealing with the underserved, non-served, very sick of the sickest kind of population, so you don't get that economic value. So that's conundrum number one. I think the thing that the approvers are now, like CMS in the United States, are tending to accept international data a little bit more, because then they can get a little bit more of that economic data that is more defensible for them. So like right now, we have percutaneous valves, right now are being considered at the U.S. when they've been available overseas for 5-6 years now. And so it's only after having some of that outcomes data overseas that they're starting to say, yeah, maybe we should kind of look at that and let's see what the cost-benefit analysis of that is. Right now, the only people that can get it are people that have absolutely no other hope and they can pay for it out of their own pocket, or that it's being paid for by the research trial. Whereas everybody else in the world can get it somewhere else. It's kind of annoying. But that's the way that, unfortunately, we used to be the cutting edge of all this stuff, and the United States is not. They've relinquished that, and I think they're doing it intentionally at a policy level. Because the last thing they want to have is this huge proliferation of something that's overpriced, overutilized, and maybe not having that economic value. And I can give you tons of examples of where that's been the case, to tell you the truth. So they've been burned a lot, and they've learned to be very skeptical. I don't know if that answered your question, but that's my...
That was a really good insight.
Okay.
All right, so the last question, Adam.
I'm not a policy expert by any means, but I do read the newspaper. And there's two things that seem to make a lot of sense to me, but I don't know really what's going on in the background. But as far as getting insurance across state lines and stuff, I never understood why that was unavailable. And then also Medicare, working with pharmaceutical companies to negotiate drug prices. Those two issues make our current stance make zero sense to me, so I was just hoping you could elaborate on those.
All right, I'll try to make it really quick because those are it's interesting. So it's the first question about getting insurance across state lines is almost akin to being licensed across state lines. It's almost identical, and it's based on state law. So insurance law is a state law. It's not a national federal law, unless you get to ERISA, which is an exemption that large employers can take advantage of. The bottom line is, and unless the federal government takes over insurance law, which no state is going to be willing to relinquish that because they have this whole infrastructure set around it, it's just really, really hard to do. So this is a big controversial thing for the feds to come in and federalize stuff. I mean, we're a republic, kind of go back to your kind of politics 101. As a republic, states' rights really, really make a difference. That's the way the whole Constitution was established. And all of these things that as we get more sophisticated and we want things nationalized, which seem to make sense, goes against the fundamentals of the Constitution. So it's completely, you have to push common sense aside and realize that in this case, it's this historical state law dynamic that's making this very, very controversial to do. But I agree with you in premise, but that's what's driving that one. And again, same thing with licensing. So telemedicine, like you guys could, diagnose somebody in California very easily, but seriously, the California Medical Association or the Board of Medicine will be darned if they're going to accept your Ohio license. They're going to want you to pass their board and their bar. They mean the same thing with law. I mean, it's these states' rights. They're huge annoyances. All right, so that's that. And then the second was on pharmaceutical negotiating pricing. So that makes perfect sense. And over a beer, I could tell you the true story. But it was a deal that was cut. I don't care what anybody says, that there was, we were all in the White House cutting a deal that if we spent a ton of money passing Obamacare, that they would not price the pharmaceuticals under Medicare, that we could still operate in the private market. So it was a deal. The pharmaceutical industry and Obama. There we go.
Making sausage, I think is what they call it. So.
All right, well, thank you so much for being here and speaking with all of us, and let's just give Ms. Morris a round of applause.